Hello, my name is Michael Pillinger, and I'm a rheumatologist at NYU School of Medicine. This year, it's my privilege to be the Gout and Crystal Diseases editor for Rheum Now here at the annual meeting. So I'm speaking to you today on the first day of the meeting. So what can I tell you about gout at the ACR so far? Well, not much really. It's been a quiet day. So instead, I'd like to update you about an event that happened the day before the meeting. Many of you may not know about GCAN, the Gout, Hyperuricemia, and Crystal-Associated Disease Network, founded and currently directed by Bob Turkeltaub and Hyun Choi. If you don't know GCAN and you care about crystal disease, you really should. GCAN is a lot like ORSI for osteoarthritis or GRAPPA for psoriatic arthritis. It's an international organization that brings together gout and crystal disease folks to share science. It helps set priorities to move the science forward, and it works really hard to give opportunities to junior investigators. GCAN holds its annual meeting these days the day before the ACR, and this year was no exception. At GCAN this year, there was some great basic and clinical science, and not all of it will be presented at ACR. So I thought I'd highlight a couple of presentations today that I think fit together quite nicely and help underline the profound nature of inflammation and gout. The first was a presentation by Dr. Leo Houston of the Netherlands entitled Epigenomics of Gouty Inflammation. Leo spent a number of years working on the fascinating concept of trained innate immunity. We tend to think that only B and T cells can learn anything, but it turns out that the innate immune system can learn too. It doesn't learn in the same way as the acquired immune system does. That is, it doesn't learn to become more specific, but it can be reset in its ability to respond to pathogens and internal danger-associated molecular patterns. For example, if you lived in an area where infections were common, your innate immune system would go into a sort of overdrive, as if it knew that it needed to be ready for the next event. It's like turning up the thermostat, or to borrow a concept from the movie This is Spinal Tap, it turns its own volume up to 11. So why do we want to talk about this today? Because Leo and his group have shown that one way to turn up the innate immune system is to expose it to high levels of soluble urate and not crystal urate. So patients who are hyperuricemic have higher levels of cytokines like IL-1 and IL-6, higher CRP, even when they're not having gout attacks. And these changes, while not permanent, are very persistent because their basis is in urate-driven epigenetic modifications. In particular, Leo has demonstrated histone methylation in the setting of urate, but other kinds of modifications like DNA modifications may also be pertinent. One area of immediate research interest that Leo spoke about are the possible epigenetic roles of long non-coding RNA, which can both enhance and inhibit translation. Leo has demonstrated that these RNAs may have effects on cytokines like IL-8, CXCL1, 2, and 3, interleukin beta, and the anti-inflammatory cytokine IL-37. So innate immunity may be pre-wired, but it isn't inflexible, and urate plays a role in persistently revving it up. The second GCAN story I want to highlight now was presented by Dr. Jacob Wozniak, who was giving the Ralph Schumacher Early Career Investigator Lecture. What Jacob showed was that gout patients could be broken into two groups based on low or high serum urate levels. Low or high serum IL-8 levels. Those with high IL-8 were basically revved up for innate immunity, in that their peripheral blood monocytes also had broad proteome changes with expression of mitochondrial and oxidative proteins, nucleosomes, and AP protein coat complexes. Then their group looked at what happened after long-term xanthine oxidase inhibition, such as allopurinol, which not only lowers urate, but also reduces oxidative stress and inhibits the NLRP3 inflammasome. The results were complex, but the authors identified increased M2 anti-inflammatory macrophage markers going up, including TGF-beta, inhibition of inflammasome-driven IL-1 beta, and limitations of a keratinocyte-like cell subset, as well as inhibition of pro-inflammatory migratory monocytes. The long story short, in patients with hyperuricemia or gout, their innate immune responses are persistently programmed to be wound up well beyond normal. But the good news is that proper treatment, potentially with a xanthine oxidase inhibitor, may rewire the system to reverse the chronic hyperinflammatory changes of the disease. Thanks. I'll see you next time when perhaps we'll focus on some more clinical issues. Tune into Room Now for more reports and videos.